Assalamu alaikum wa rahmatullahi wa barakatuh. We would like to welcome you all for our second day afternoon session. And this is one of the sessions that's really dedicated to acknowledge the work of the anesthesiologists during the pandemic. And this session is called the COVID Pandemic Heroes. All the healthcare workers suffer in the last few months the pandemic effect, and they really did an extremely and extraordinary work. Anesthesiologists are part of the healthcare worker in any institute. They have really a great talent, and they manage with their colleague in all specialties to go through this period, and hopefully we'll have this over very soon. Today with my colleague, Dr. Maan Qattan, who is the chairman of Anesthesia Department in Jeddah National Guard Hospital. We will take you for the next 1 hour with the two distinguished speakers, well known. I think from their name, you will identify them very well in the kingdom and also in the Gulf region, not even national and international. We would like to welcome Dr. Abdulaziz Al Ghamdi, the CEO of the Eastern Province Cluster in the Ministry of Ministry of Health. He's a Canadian board graduate at the University of Winnipeg in anesthesia and did cardiac anesthesia and intensive care unit fellowship. The second speaker is Dr. Mohammed Al Zahrani. He is the Executive Director of the Medical Services in the Western region. He's a surgical oncology with MBA graduates. He's one of the best surgeons I ever worked with him while he was in Riyadh. Then he moved to Jeddah as the Executive Director. We will not take long. We will open the discussion at the end of the session, and would like to introduce Dr. Abdulaziz Al Ghamdi for his first lecture. And please welcome Dr. Abdulaziz.
Assalamu alaikum, massakum Allah bil khair jami'an. Thank you so much, Mr. Chairman, for this introduction. I would like to share my slides first. So, do you see it in the screen now?
Clear.
Okay. So I would like to share with you today the anesthesiologist role during COVID. And I'm going to mainly discuss from the eye of not just as an anesthesiologist, but also as a leader in the health sector in the Ministry of Health. I'll just go, just a second. Yes. So I'll just share a quick history of the start of the disease. As we know, it was started in December last year, started from Wuhan in China, and then spread all over the world. In January 30, end of January 2020, it was announced as a pandemic disease by the World Health Organization. And we got the first case in the kingdom on the 2nd of March from the Eastern Province, from Al Ghatif. It was reported from Al Ghatif Hospital. Just going back here, why COVID-19 is a major disease? It's actually because of the huge impact on the health sector. It's not just from the ICU point of view or from the emergency department point of view, but also from the whole system, from the supply chain in regard of material, equipment, from the staff manpower, qualified manpower, from the ICU, mainly from the facility itself. We know that in an average, 10% of any hospital bed occupancy is for the ICU patients, designated for the ICU beds. And the hospital are built around that support surface. So there was a huge impact on the facility and the electrical load and the oxygen tank supply. So truly, it's affecting the whole healthcare system in any country. Also, displace the care. So initially, we were focusing on elective cases. We had, in a period of time, to focus our care to mainly pure COVID-19 patients. In general, the ICU beds in the hospital, and I am talking in the kingdom mainly, it was doubled or tripled even to cope with the high requirement and high demand of the ICU beds in the region. But the major impact was on the remote hospitals, or whether we call them the rural hospital more than the city hospitals. So it was the anesthesiologists, with the help of the anesthesiologists, were able to convert a lot of ORs to ICU, a lot of recovery room to ICU. So there was huge building of capabilities in all these hospitals. So in the new situation, there was a major impact on the healthcare system, spread of the disease with limitation at that time of the resource or the training that we have for the ICU, mainly huge demand required to deal with really sick, really or very sick patients requiring critical care need. There was also, at the same time, requiring and the demand of highly qualified people to deal with airway management, to deal with very sick patients. At the same time, there was also demand to continue the semi-elective procedure, the urgent care required for cancer care patients, MVA, trauma patients, transplant patients, that we were required to continue providing the care to those group of patients. So we designated in the not just in the Eastern Province, but in the kingdom, the whole kingdom, a center mainly deals with COVID patients and non-COVID, another centers for non-COVID patients, or what we call them the green hospitals. So the impact of COVID-19 pandemic on the anesthesia practice through different phases was significantly. So there we could say that there was the pandemic phase, the transitional phase, and the post-pandemic phase. To be prepared for all these phases, there has to be a program, protocols to educate and protect the patient and the staff. And this is by establishment of universal screening. And this was in the beginning of the COVID, where we had to continue our elective procedure or semi-elective procedure, but there was a risk of spreading the infection from the patient to the staff or vice versa. So their screening program was issued by the Ministry of Health for any elective procedure. Also, there was modification on the practice. Initially, we used to have the patient come to the clinic, anesthesia clinic, to be assessed. Instead, creation of virtual clinic was carried all over the kingdom to ensure that there is a minimal risk of getting the patient infected or even the staff. Also, providing new medical facility near the patients in the form of utilizing the primary care to be as a mini surgical procedure or day procedure cases where we send some of our anesthesiologists to that primary care to conduct anesthesia under local with minimal sedation to avoid bringing the patient to the hospital. Also, one of the major changes that took place in our ICU is converting them all to negative pressure ICU and converting the OR to an ICU to a negative pressure. We know in general around 10% of the ICU available in any hospital, it should either be a negative in addition to positive, take care of those patients. We had to convert all the ICU in our hospital to truly negative ICU and ensure that each ICU is equipped with HEPA filter, taking out unnecessary equipment like IV drips, material, equipment inside the patient ICU patient room to be located outside to avoid contamination. Also, designated specific area before entering to the patient room for the staff to wear their PPEs and ensure that all gears are placed before exposing to the patients. At the same time, there was a lot of educational session taking place to ensure that safe practice is conducted by the staff. So there was a lot of international anesthesia organization conducting a lot of conferences, and we had one of the biggest conference related to COVID and COVID practice in the early phase that took place in end of March in Dammam Medical Complex in the Eastern Province to provide educational to the staff. Also, in addition, there was a lot of online discussion session conducted by matter expert from the Middle East respiratory syndrome. We all know that Saudi had great experience with the Middle East respiratory syndrome, the corona that took place around 6 years ago. And H1N1 also, SARS had also, we had matter experts from SARS to share their experience and to share their knowledge with the staff, mainly for the anesthesiologists, how to protect themselves and to avoid of spreading of the infection. I must say that also Ministry of Health done a great job and retraining or providing courses, educational courses to staff working in a non-critical care or in a non-critical zone environment. So they had, for example, the critical care crash course provided to GPs or general practitioners, in addition to provided to the nurses to ensure that they were able to provide cares if needed, if there is a shortage of specialized physician in the ICU or nurses specialized in the ICU to provide the help. And actually, it was very, very handy as we utilized more than 800 nurses working in non-critical ICU area to start working in the ICU. Also, provide refresh courses for some of the physicians, and most of these crash courses was conducted by anesthesiologists to ensure that they share the knowledge of critical care experience with general physicians. This is some of the templates that was created by the Ministry of Health to ensure the staff are get updated. I would say with confidence that the anesthesiologist took the lead in this crisis. And this is because of the nature of the disease and the skills and the experience anesthesiologists have to deal with the physiology and pathology of respiratory system. The majority of, and this is from the statistic point of view, the majority of physicians practicing ICU is from anesthesia background. I would say at least 70% of the ICU covered, especially in the rural or district hospital, are covered by anesthesiologists. In addition to around 50% of the physicians in the major cities are covered by ICU, covered by anesthesiologists. So this has had a major impact and has an outcome of the facility to cope up with the disease. With the increased demand of ICU capacity in the hospital and the number of patients requiring mechanical ventilation, it's not just the ICU designated facility, but also in the step down and the regular wards. As we know that most of the patients with COVID, especially if they have respiratory system, they will deteriorate quickly, and sometimes there will be no time to move them to the ICU to be intubated there. So anesthesiologist was covering in the ward and in the step down unit to ensure that there is a quick secure of the airway and immediately transferring the patient to the ICU. Anesthesiologist plays a major role in transferring critical ill patients between the hospitals, especially if they are hemodynamically unstable and requiring matter expert trained physician to be accompanied to the patients. And this is mainly at the beginning of the crisis. As we know, we got the paramedics to start be trained, but some patients required anesthesiologist care. Also, there was a need for the non-ICU ward patient to who are very sick to have anesthesiologists covering the hospital 24 hours, 7 days a week, mainly at the rural hospitals. In many of our hospitals, we created an airway management team that was mainly led by anesthesiologists, as they are matter expert in securing the airway in a very safe way to ensure securing the airway with avoiding contaminating the area or the zone intubation will take place. And this took place in our Eastern Province in the early phases of the COVID. As the number got higher and with limited capabilities of securing the airway in a very safe way, we had to develop this airway management team. Well, I believe they done a lot of great achievement and successful story by minimizing the negative impact of the disease on the intubation zone or where the intubation took place, and also securing, improving the airway or improving the oxygenation of the patient in a quick, safe mode. The main goal or the principal goal that the anesthesiologist had when they are securing the airway is to minimize the generation of aerosol. So bag mask ventilation before intubation or having the patient cough during laryngoscope or during placing the tube was minimized to the lowest possible to avoid the spreading of airway droplets or air droplets. Also, pre-oxygenation was done with a high-flow nasal cannula in most of the time to avoid pre-oxygenating with bag mask or positive pressure embobagging of the airway. Also, to avoid agitation and having the patient cough, most of the patient were rapidly secured their airway using rapid sequence induction. To secure the airway, and we had to designate a card, or we call it the airway crash card, in each ward. And it was placed outside the patient room, mainly near the patient, near the nursing desk station, to avoid the risk of contamination if it's inside the patient rooms or inside the step-down unit. But we used a lot of video laryngoscope to replace the plate as much as we can, and to have the replaceable plates used as much as we can also. We know that if we have patients suspected to be a COVID, the full precaution or ultra high precaution was taken to ensure that the safety of the staff inside the room or even the anesthesiologist who's going to intubate the patient. So this is glidoscope was used in most of the cases, I would say. And this is the protocol that was shared by Ministry of Health with all the hospital to secure the airway in a very safe, practical way. So when also difficult airway is anticipated, flexible bronchoscope intubation can be performed using a video bronchoscope. Awake fiber optic intubation was avoided as much as we can, and also extubating the patient with the minimal agitation, avoiding cough, was critical, especially in the ICU patients when when they met all the criteria for extubation. We had to ensure that they are extubated in the presence of anesthesiologists or by anesthesiologists to minimize the risk of coughing or spreading the infection. Anesthesiologists should use their knowledge and skills beyond the operation. So they were contributing in a different level in controlling the infection and risk and minimizing the risk of infection. I'm going quickly here off of the slide because of the shortage of time we have. In many hospitals, airway team member took charge of ventilating and managing after tracheal intubation, and especially in the first few hours to ensure that the patient is well ventilated, well oxygenated, according to a specific protocol that was placed in the ICU. Also, when mobilizing the patients, or mainly placing the patient in a prone position, anesthesiologist has to be there to ensure if there is accidental displacing of the tube, will be able to manage. So teams were developed to turn the patient from spine to prone position. Some ICU patients develop an ARDS that was difficult to manage with the conventional mechanical ventilation. So ECMO was placed, and it was with the presence of anesthesiologist, or with the help of the anesthesiologist accompanying the cardiac surgeon. Also, with their good experience in ultrasound, anesthesiologists were able to identify some of the early identification of some of the complications that took place for patients on the mechanical ventilation, especially if there is an pneumothorax or pleural effusion or displacement of the endotracheal tube. So I would say in general, and during the outbreak of COVID, the most important consideration for clinical anesthesia is infection control and spread of the infection. And anesthesiologists play an essential and a major role in the preoperative evaluation of COVID-19 infection risk. Even though some patients were labeled as low risk, with the anesthesiologist, when they assess those patients, especially before their surgical procedure, it was very clearly that they were high risk, converted to high risk, as some of them were in contact with positive patients and they were never diagnosed as having a COVID. So the strategy that was placed to expand the capabilities during COVID-19 focused on three pathways: redirect the patient demand, and relocate the staff, and reuse the local available supply as much as we can. I'm going quickly here over the slide, but one of the most important factor that we should not ignore is the psychological support for the frontliners. And as we mentioned here, that most of the frontliners are anesthesiologists. So there was a worry of depression. There was an anxiety component. There was also a worry of spreading the infection to their staff. So there was a lot of fear, psychological impacts on the anesthesiologist lifestyle. This picture is, could explain itself on the heavy extent impact that the healthcare worker had from COVID. We had in the Eastern Province post-traumatic psychological support team and clinical, a hotline for clinical psychological assessment and consultation to our staff. And most of those staff were dealing with, were working in the ICU, and some of those were from the anesthesia practice. Clear communication with regular and accurate update to the staff was critical, and we had to make sure that this kind of practice is conducted in our facilities. And also MOH done a good job with good communication to the public through a regular session and update that took place in the beginning as a daily practice. From from the OR, we have to make a recovery plan for all the delayed cases that was canceled. And I think this was planned by most of the hospitals. In a conclusion, anesthesiologists were essential to various critical aspects of the response to the outbreak of COVID: early invasive and non-invasive ventilation, establishment of an airway management team, and fast response resuscitation team was critical. With the change in the epidemiology character of COVID, patients, anesthesiologists took a responsibility of the infection control as well. And finally, our thought and prayer are with the families of the healthcare heroes who lost their lives for COVID. And thank you so much.
Shukran, Dr. Abdulaziz. Thank you. So without further delay, we'll leave the questions and discussions after 2 o'clock. Our next speaker, as presented by Dr. Mohammed Al Harbi, is Dr. Mohammed Al Zahrani. He is an oncology and endocrine surgeon. He's the executive director in the Ministry of National Guard Health Affairs, King Abdulaziz Medical City National Guard, Jeddah. He's going to talk to us in the next 30 minutes about the preparedness of the crisis. تفضل دكتور محمد. If you want to unmute yourself. الصوت دكتور محمد. ايه ممتاز. بسم الله.
طيب يعطيكم العافية. السلام عليكم ورحمة الله وبركاته. I'd like to thank the Saudi Anesthesia Society for inviting me. It's an honor to be with you today. I'll be presenting some tips and some lessons that we've learned during this tough year of 2020 in combating the COVID pandemic. This short clip actually is the way I envisioned when I was a medical student the laughter gas of anesthesia. But then I realized when I started working with Dr. Mohammed Al Harbi that there is no laughter and there is no color in the gases. So starting with the building blocks of my talk, which is going to be around 15 minutes, I'll start talking about some overview on the impact of the pandemic overall. As we know that the pandemic actually has, did strike the entire globe, and that has resulted in a major adversities across the board in different disciplines and different domains in the human life. And we'll touch base with that. And then we'll talk about some reflections on the preparedness to combat the unknown demands and the unknown risks dealing with the pandemic or dealing with any crisis in the healthcare system. And then we'll turn to talk about some important aspects in the role of anesthesiologists during the pandemic and how they played an integral and a core component role in the healthcare system to survive the pandemic and to come up with solutions and innovative ideas. And then we'll conclude by some to-do list and some thoughts. The impact of the pandemic, as we said, is huge. So the crisis since the beginning of the year has been huge, and the impact has been tremendous. However, there is also a huge learning and a huge opportunity to think how to deliver the care to patients during exceptional times in some alternative ways that provides the right care and also does not compromise patient cohorts across the boards and across the specialties. If you stretch the line and the timeline from January 2020 to December 2020, until last night, we had almost 66 million cases of coronavirus and around 1.5 plus million of mortalities due to coronavirus. Nationally, I think until yesterday, we had almost 350,000 cases, and the mortality is in the order of around 6,000 cases, which keeps the mortality, alhamdulillah, low at 1 to 1.3%. But looking at the economy, if you look at the global economy curves, comparing it from early 90s recession to 2008, 2009, and then to 2020, which is the red line, there has been a huge global economic recess. And this translates into adversities and unemployment, as you can see in the second chart here. where the unemployment actually jumped, for example, in the United States from 3.7 to 10.4. So you're talking about threefold unemployment just during the first 6 months of the pandemic. That's so huge, affecting humans, affecting families, and affecting businesses. This was a statement that was stated by the World Health Organization on October 13, 2020, where the economic and social disruption caused by the pandemic has been devastating. Tens of millions of people are at risk of falling into extreme poverty, while the number of undernourished people currently estimated to be at 690 million, would increase by at least 132 million by the end of this year. So the impact is huge, and it's needless to say that the world has been affected so badly by the pandemic. Now, if you focus and zoom in into the healthcare, what was the impact? The impact is huge, obviously, because the healthcare system is in the eye of the storm, where healthcare workers have been affected. Luckily, the incidence or the percentage of healthcare workers being affected in proportion to the overall number is not too huge, especially nationally. We're talking about 7 to 10% of healthcare workers have been affected, and the mortality is observationally low. Unfortunately, I didn't have numbers, but the number is low, and that's a good news, and that speaks for the excellent preparedness of the healthcare system and healthcare workers. The huge budget expenditure during this year. There are a lot of projects in healthcare system that was planned over the previous few years that the budget of which has been shifted in order to combat the pandemic. So the expenditure has been so huge just to empower and enable the healthcare system to survive and to stand the huge impact of the pandemic. And then the subsequent backlog of I call it the non-pandemic pandemic, where after the pandemic is over, we'll have another pandemic of those patient cohorts who are waiting for their care, who actually have chronic diseases, waiting for their surgeries, waiting for their chemotherapy and cancer, waiting for radiation treatment, who have been waiting and their care has been definitely compromised, where the chronicity of the disease has been accelerated because of suboptimal care delivery. So this is another challenge that we will be facing, and we started actually attending that need from now during our de-escalation processes. What are the reflections on the preparedness, combating the unknown demands and risks? First of all, if you look at the healthcare system, when it faces a pandemic, looking at the original equation of any healthcare system, it's an equation of demand capacity. You are having an ongoing emergency demand, which is not avoidable. You're having a wait list pool of patients waiting for their procedures, interventions, or treatment episodes. And also you're having your ongoing elective demands. So that is your demand. And in face of the pandemic, you're having a COVID pandemic where there is a great deal of uncertainty. There are, critical care capacity issues. There are a lot of issues that would definitely compromise your ongoing equation of demand capacity. So you'll be working with moving targets, and you have to be resilient enough in order to meet the demand and sustain your clinical operations. And this is the famous curve that has been published and circulated tremendously over the last 1 year. That talks about how to blunt the curve in order for the healthcare system with a finite capacity in order to deal with the situation. As we have observed since the beginning of the pandemic, that some strong healthcare systems have been crashing down just because this curve was not blunted on a timely fashion in Europe, in the US, and in the East as well. This has been a significant challenge. Luckily enough, alhamdulillah rabbil alameen, in the national healthcare system, with the collaborative efforts and the leadership directives, and this curve has been blunted efficiently, alhamdulillah, and the healthcare system has been running efficiently without any suspension or crash, walillah alhamd. So what makes an organization successful, especially during exceptional times? If you look at it, we talk about 3 components of any healthcare system. We talk about a capacity, so you have to handle the capacity appropriately. You talk about the safety, and you talk about the efficiency of your clinical operations. When we talk about the capacity, obviously, the capacity is not only the space. The capacity speaks for trained staff. So you have to be ready with your talent, manpower in order to uplift and leverage your capacity to be up to the responsibility and up to the demand. And obviously the infrastructure, which is the space, the technology, the assets, and etc. But besides the capacity, although you're having a finite space in the healthcare system, you can actually boost the capacity by being more resilient and by injecting and embedding into the DNA of your structure some soft organizational skills, where you can actually lean the processes of your healthcare system in order to minimize the encounter of the patients and to minimize the journey of the patient during his or her care episode from door to door. And this speaks for cutting the waste time, the value added time for any patient who comes either to emergency or to elective services. There's a lot of waste, and if you can play with this, you can boost your capacity. So there is a difference between a 100-bed hospital with a length of stay of 10 days, for example. When you perform some Kaizen events and some initiatives and quality initiatives, you can double your capacity just by decreasing the length of stay by 50%. So in other words, you'll end up having 200 beds when in fact you're having only physically 100 beds. When you talk about the efficiency also it speaks about how to be customer centered. So all your initiatives, all your plans should be centered around the patient. And also you have to be resourceful. So appropriate utilization of resources is the key to efficiency in healthcare systems. And that definitely will translate positively in your budget and cost as well. Safety is a wide concept, and it's a very essential concept in any healthcare system. We're not talking only about patient safety and minimizing the harm, but also the safety to the healthcare workers against the possible harm just by working in a healthcare system, or the possibility of them being harmed or if there's any violence against them. So this has to be taken into consideration in any healthcare systems, and also the safety of the assets and premises as well. So this is a global bird's view of how to look at a successful story in any healthcare organization and how to integrate all these efforts. Obviously, moving fast is so essential. This is Anthony Fauci, who said, when you're experiencing an outbreak, don't ever underestimate the potential of the pandemic. And to prove this is a little story of a whistleblower who is a physician in China, actually, who his name is Li Wenliang in Wuhan. He initially spread the concerns about SARS-like illness before actually the Chinese authorities and before the WHO actually has started talking about this. So he started spreading the concerns. Because of this, the security forces in China detained him for false allegation. And unfortunately, he died at 33 years of age on the 7th of February 2020 because of COVID-19. This is a paper that was published in UK, and that looked into the effect of non-pharmaceutical interventions for containing the COVID-19 outbreak China. And they actually started their timeline if these interventions were implemented during the time of this Chinese physician when he started raising his concerns. They used some mathematical models, and they estimated that 95% in China cases would have been cut by acting just 3 weeks earlier. So early, alarms, we have to have our dashboard system. We have to be really having a very low index of suspicion when we deal with an outbreak. Coordination is a very, very important component in dealing with crisis. Coordination is not easy, it's hard, but it is essential. We cannot go without coordinating efficiently with different stakeholders, responding to the daily dynamics and moving targets. and dealing with many stakeholders in order to put them all in one platform on the same page so that they move together towards the goal. The value of daily huddles is very, very, very important. And maybe Dr. Maan Qattan remembers that during the beginning of the COVID pandemic, we actually had a daily huddle of a long stretch of 100 days, 30 plus people meeting on a daily basis, weekdays during Ramadan, just talking about the daily updates, daily concerns, which are unavoidable, concerns and challenges will arise every day. And then the rule of this daily huddle is to talk to each other and solve it as they arise. So the framework of having this orchestrated work is that we had an emerging pathogen preparedness committee, which is comprising all the key leaders of the healthcare organization with the direction of the corporate management of MNGHA, where this committee allocates the resources, plans, implements, and monitors the regional readiness for response to the pandemic, and receives updates and discusses and resolves the business challenges. Out of this committee, we had subcommittees that deals with the infrastructure capacity and how to plan the upsurge capacity, the isolation, the critical care capacity, and all that, and to test that we are ready for the strike of the pandemic. Another subcommittee which takes care of the staffing, because we know the staffing is a major issue when it comes to healthcare workers covering the pandemic and covering other services, and also the support staff. So there was a staffing committee that prepares in parallel to the infrastructure capacity, the groups of healthcare workers and support staff to be dispatched as we move on with the escalation mode. The training subcommittee has been doing really major role, where we all realize that we have a shortage of critical care MDs, anesthesiologists, respiratory therapists, and critical care nurses. So there was a module for training these people and an online database for that. Volunteering service, this has been also by the royal decree, and this has been implemented, and I think it helped a lot. When we built a database, we were surprised that in 24 hours, we started having an influx of 200 plus people who are willing to volunteer during the COVID pandemic. And, we prepared some, training modules for them based on the area that they will be joining. The scientific committee is another subcommittee that actually was in charge of generating the best possible evidence out of how much is coming in the literature, coming up with guidelines. And so far we having the 7th edition of the COVID scientific guidelines, which is a huge document actually in 300 more pages that deals with COVID issues and different clinical disciplines. With that all, the Disaster Preparedness Committee amalgamates all these efforts in order to put some policies and procedures in order to have a system approach to the preparedness of the committee, to the pandemic. Now, talking about anesthesiologists in the operating room and beyond, as we know that, anesthesiologists, traditionally people were perceiving anesthesiologists as physicians taking care of patients just inside the operating room. And I was surprised really when I was preparing for the talk today that I encountered this paper that was published in New England Journal of Medicine in 1950 by an anesthesiologist talking about the contributions of anesthesiologists to the general practice of medicine. And I quote, "It appears evident that many physicians are totally unaware of the kind of knowledge that the anesthesiologist has at his command." Now that's in 1950, but I think right now everybody realizes, whether other healthcare partners or healthcare leaderships, they realize how important and crucial is the role of anesthesiologists in running the systems, especially during tough times. And then I started thinking, when you talk about anesthesiology, pandemics, and public health, I tried to put a link to all that, and it was not easy. But I was surprised really when I realized that John Snow, who is a pioneer anesthesiologist in the UK in the 80s, He actually is the one who drilled down the pathogenesis and the mode of transmission of cholera. He's an anesthesiologist. And he challenged the widely accepted theme then, where cholera is transmitted through the bad air. And he started doing the contact tracing. He looked into the cluster of cholera, and he started doing the infection prevention control measures that we're doing nowadays in order to isolate the cases. And he realized that this is a waterborne, the whole concept of waterborne pandemic has been nailed to Jon Snow. Secondly, Jeremy Adams. He is still, occupying the position of Surgeon General in the US. And Surgeon General means the US Commissioner in Public Health. He is an anesthesiologist too. So you guys rock. Now, looking at the multifaceted expertise of anesthesiologists, starting with the airway management. Obviously, the airway management is a primary expertise field in the field of anesthesia, where intubation, especially during the COVID pandemic, is a difficult intubation. So no easy intubation with COVID. It's a difficult intubation, invasive and non-invasive ventilation, the aerosol generating procedures. All that risk is mitigated and successfully managed by anesthesiologists. Emergency airway in case is needed. Beyond the airway management is the critical care and the support to the critical care colleagues, where this has been demonstrated very successfully with pride in many hospitals, including National Guard and Riyadh and Jeddah and other areas, where entire floors were transformed into ICU setting and totally clinically managed from A to Z by the colleagues of anesthesia. So that's really something that we're proud of. Oxygen therapy with all its details, ECMO, participation in dealing with patients who need ECMO, resuscitative care, all that is attributed to the huge contribution of anesthesia. You talk about healthcare transformation. With the pandemic, there has been a lot of steps in order to transform the healthcare and to provide other ways of delivering the care in a safe way and efficient way. Perioperative medicine is a hot area of anesthesia that deals with the patient before, during, and after the operations. And this is a whole a specialty that belongs or is under the umbrella of anesthesiology. ERAS programs, which is a highly efficient program to enhance the recovery and minimize the length of stay. Their procedure concept and maximizing that, digital health, all that has been contributed by anesthesiology. Now, the science and administration, the anesthesiology, generate evidence, gather evidence, and dealing with pandemics in collaboration with other colleagues across the disciplines. Design PPEs, and we have seen that actually. Anesthesiologists have designed, some special equipments in order to protect and to minimize the risk of infection during intubation, and that's not only protecting the anesthesiologist but also the entire team and whoever is in the operating room. And then real-time management. They are anesthesia services are a component, an essential component of escalation and de-escalation modes, which is always a swing back and forth between escalation and de-escalation based on the real-time situation. So conclusion, did we learn a lot? Actually, there are some tangible learning missions that we've actually gained even probably without feeling it, compared to 2015 and 2020. When we encountered the MERS-CoV in 2015 compared to 2020 with the COVID, if you look at the number of cases, 15 to 20, it's at least 1,000 times. However, there was no single system interruption, which was encountered actually in 2015. The number of healthcare workers is a third of that in proportion compared to 2015. So that means actually the healthcare system in Saudi Arabia has learned a lot during the MERS-CoV. And that actually translated into these favorable numbers, although probably we can't measure it by the scientific method. What is the to-do list so far? There is a lot to do. We need to do a lot of investments in frontline assets, anesthesia, critical care, respiratory therapists. We need to invest on long-term transformation towards digital health and innovation. And this is a huge area that I didn't have time to touch base during the presentation, but everybody realizes that now investment in digital health is the way to go. Public health and primary health care is the right investment to align it and to make it a real partner with the secondary and tertiary healthcare systems, and then to stay always customer centered. And that is the issue that's going to maximize the patient experience and patient satisfaction, and not to ignore that part of the customer here is not only the patient but also the healthcare workers. So tailoring our plans and our initiatives towards satisfying both the internal customer, which is a healthcare provider, and also the external customer, who's the patient, is actually the way towards a healthcare business successful model. Thank you very much.
Thank you so much. It's really a very thrilling lectures. Thanks, Dr. Zahrani, for this really great lecture. And also I'd like to thank Dr. Abdulaziz Al Ghamdi for really an insight anesthesiologist as a leader, especially in the Eastern region there, and surgeon anesthesia leader in the Western region. It's really put all together. We have actually, we're reaching towards the end of the session, and we have some question were related, actually, both of you as leaders, they mentioned is any special pay or extra pay for anesthesiologists to do this? This is one of the questions that has been raised. So I will open maybe Dr. Zahrani, if you'd like to comment.
Actually, thank you for the question, which is nice and tricky as well. Probably also Dr. Abdulaziz will help me here because he represents the Ministry of Health, which is the mother platform for the whole entire healthcare system. But as far as I remember, there is definitely a royal decree that dictates that there should be some overtime for all healthcare workers who've been working during the pandemic directly during the, I think 6 months, if I'm not mistaken, Dr. Abdulaziz. And I think there has been a work in this line probably. It's not completed yet, but definitely there is a royal decree that dictates that.
Actually, the payment, as you mentioned, that there is an offer time for as a payment to all the staff contributed in the crisis, in the COVID crisis. But when it comes to financial payment, I would say that there are a lot of people. It's not just the anesthesiologist or the physician or the staff working in the health sector contributed to the COVID. Also, there is a lot of an army of people from the security forces, the general. What I want to say is policemen during the crisis contributed, and law enforcement people to enforce the quarantine, the lockdown, done a great job. The public also, they done a great job in maintaining the social distance, wearing the PPEs or the face mask, hygiene. All those are contributed to reduce the risk of spread of COVID in the public. Are we going to pay them all money? Money is not everything, but it's
واضح. Yeah, clear. طيب الله يعطيكم العافية. If there is any question, Dr. Maan?
لا أبدا بالعكس. I would like to thank our speakers. Both of them had done a great job into trying to explain what we went through throughout the pandemic, and I think it was very enlightening. It's a great opportunity for learning, and it's a great opportunity to actually provide back to the societies هذا واجبنا وعملنا كأطباء دائما وأبدا healthcare workers, and I think this is the most important part. الأجر عند الله قبل كل حاجة.
صحيح.
وثانيا أحب بس أوضح إنه فعلا زي ما تفضل الدكتور عبد العزيز في البداية والدكتور محمد بعده كانوا بيقولوا they talked about it so much. The psychological or the emotional impact during the pandemic was far beyond what we expected and we've seen before in the past years. And I think this is something that should not be taken out of the context. فالله يجيب الخير وإن شاء الله ربنا يعدي البانديميك حقت النون كوفيد كيسز على خير بإذن الله الفترة القادمة وربنا يجيب الخير.
I think we reached to the end of the session. We have actually many questions, but the time is really reaching to the end. I would like to thank both of our speakers. Really a great and a very informative lectures, very coming from leaders in the kingdom. I would like also to thank Dr. Maan for your great help, and for also the participant today, 526, really an excellent thanks to you all, and apologies if we cannot catch your question. Just a reminder that the next session will be starting in 2:15 with abstract competition, and hopefully that we will be enjoying that. 2:30 there will be cardiac anesthesia, and followed by regional anesthesia workshops. All the best, and thank you all for a great contribution.
Thank you.
Thank you very much. Thank you.
شكرا لكم.
في أمان الله. شكرا جزيلا لكم.